I've had some providers reach out recently and say, hey, Victoria, my RVUs are really low and I think my coder might not be coding correctly. I've had to troubleshoot this in the past at the request of a physician or a practice manager or a regional director, so I know some of the common reasons that RVUs might be low for the month. So I'm going to talk a little bit about what is an RVU and then some of those common reasons I've seen why RVUs might be low for the month. Stick around to the end because I've got some additional resources that really will help you out. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you like medical coding content, I would highly encourage you to subscribe, hit that notification bell so you can get alerts when I post new episodes. So RVU is a relative value unit, and it is part of the methodology used by CMS, the Centers for Medicare and Medicaid Services, in order to determine physician payment for services. The other components of that payment calculation are things like the conversion factor and then your geographic location. A provider providing services in San Francisco is going to get paid more than one in rural Kentucky because of the higher cost of living for that location. Procedures that are more complex, they require more skill, more time, more resources. They will have a higher RVU. About half the consideration for an RVU is the work RVU, so that work, that time, that skill, that intensity related to providing that service. The other consideration into the RVU is your practice expense, so the cost of your office, your supplies, your equipment, and your staff. And the remainder of the RVU consideration is malpractice, so the cost of your malpractice insurance. One of the top reasons that your RVUs might be low is because of low volume. You may not be seeing as many patients in a certain month. Maybe you went on vacation or took a few days off, or there was just a low patient census. You didn't have as many visits, you didn't round on as many patients, or maybe you just didn't do as many surgeries that were as complex in that particular month, because of course those complex surgeries have a higher RVU. If you're only doing small minor surgeries that don't have a higher RVU, then that'll be a lower RVU then for the month. Or maybe you were super busy the month prior, so you saw a lot of complex surgeries because of maybe just the time of the year, that there was maybe a lot more patients in your population that at a certain time of a year come in for provider visits. And now in comparison, this month seems lower than the one where you were seeing a lot more patients or doing more complex services. Another reason RVUs could be low is because maybe the documentation is insufficient. Maybe there were services that were actually done, but they weren't captured appropriately in the documentation. So maybe they should have been billed out, but because that paper trail wasn't there, they weren't captured. For example, a patient comes in with impacted cerumen and they have it removed with instrumentation. One of the key words in there is it has to be impacted. If that word impacted cerumen isn't in the documentation, that impacted cerumen removal code can't be used. It actually goes then to an evaluation and management code if it can be supported. Or even something like a lesion. Lesion removals are often based off of size. So if you didn't document the size of a lesion or a size of a closure, sometimes depending on the structure of how the policies are for that particular organization, they might say just code it to the smallest size because we don't want to bother the provider and we're just going to get it out the door. In which case that provider will be losing out on RVUs and reimbursement because they're going to say, oh, well, even though we could get paid more if they document the size, we're just going to push it out as the smallest size. So when coders ask providers questions, it's not because they're going, haha, look what you missed, or pointing out their mistakes. They really want to capture that highest reimbursement, get those highest RVUs. So it's really important to have those good coder versus provider communications so that we can maximize those opportunities. If a provider doesn't have intimate knowledge of the CPT book, they might know those tiny little nuances about words like impacted for cerumen removal that can change the code entirely. Even going one step further, sometimes the documentation is completely missing, and you definitely don't want to miss out on doing your documentation, just like you don't want to miss out on smashing that like button and hitting the subscribe and that notification bell so you can get alerts for new episodes. One of the key things here is to really have that good checks and balances to make sure that when a provider is providing a service, it's getting captured somehow, that we're not relying on reports that are inaccurate or a provider handing in an index card with the patient's medical record number on it and throwing it in someone's desk, because those paper cards, I've seen them. The providers will put them in their lab coats, the lab coat will go through the wash, or they'll hang them up in a communal closet and forget about them. And in that case, that entire service might just drop off the face of the earth. A lot of the revenue cycle software out there now, though, does have a reconciliation report of some kind that can be run prior to closing at the end of the month, so you can identify them and bill them out in time. Especially because we have things like timely filing limits. There are certain insurances that say we want to get that claim to us at least 90 days after that service is rendered, sometimes even shorter, sometimes longer, but they have that time set, so you have to at least get a claim to them. You can sometimes later adjust that claim as needed, but you have to at least have that claim in within a certain date frame. And again, depending on the provider contract, they might say, hey, if we don't get this in on time and it gets denied for timely filing, they might impact that RVU. It really depends on how everything is structured. Now, I talked a little bit about end of month. Well, what's end of month? I mean the end of the month for the books, and we have that in medical billing. In fact, as a coder, some of the organizations I've worked at didn't allow us to take vacation days unless they were something super important the last few days of the month, because that was kind of crunch time to get all of the charges in. So say it's September 30th and a provider has that white coat with all those cards in them and they went, hey, I'm going to hand these in. I need to get these in at the last day of the month. You don't want to do that, because what might happen is, say there's only one person dedicated that's coding that provider services and they're out sick on the 30th. Well, then they're not getting in for the end of the month. They're going to get in on the next month, but not for the month that they were handed in because it was just too last minute. Some of the organizations that are super automated, let's say you're on an Epic, they might say, hey, you have 24 hours after you see a patient in the office to close that note and submit that charge. And again, depending on how things are structured, they might have certain regulations about how soon you have to submit those charges. They might have things saying that, if you don't submit them within at least 48 hours prior to the end of the month, that they're not going to get in for that month. So make sure that you're familiar with those policies. Now, going back to systems and automation, there might also be holds in the system. So let's say you submit a charge or you send something in to be charged for a patient's bill, but there's an edit in the system. Maybe they didn't hand in their insurance information. Maybe there's just something missing. Maybe it hit an edit in the system that says, hey, this needs a modifier on it and someone has to manually review it now. Those holds that go in place, again, depending on how that system is set up, might not then calculate those RVUs for them, because if the initiation of how the RVU is calculated is that it goes to insurance and it's still sitting in the system, again, depending on how it's structured, that might not calculate that RVU for that month. It's also possible that the RVUs are being held up because that service is being held by the coder. Maybe the coder reviewed the documentation and saw, ooh, there's something in here that I'm not sure about. I have to talk to the provider, or they have to research, maybe check an insurance policy, see some sort of coding clinic or CPT assistant, and see if there is a policy on how to code that particular scenario that isn't quite so straightforward. So they're holding it, or maybe they even just have to talk it over with their supervisor first because it's just a complex case and they want to make sure that they get it correct. So if they're holding that to do some research or to get some clarification and it doesn't get finished by the end of the month, it will go in for the next month, but that RVU will be short for that particular month. One of the final reasons RVUs might be low is because you could just be overestimating what the RVU value is for those particular services. Sometimes things like a lysis of adhesions are included, so you may think that you're going to get an additional RVU for that particular service, but it's bundled in. And the last reason that the RVUs might be low is because you could just be overestimating what that value is for that service. There are some services that are bundled into more complex procedures. Things like an exploratory laparotomy or a lysis of adhesions are oftentimes bundled into a more complex procedure and then aren't billed separately. So if a provider is calculating that they're going to get additional RVUs for all these different services and they're actually bundled, then they're going to overestimate their RVU for that month. Or sometimes there's a procedure that we think is really complex, Medicare has just determined it doesn't have that high of an RVU. A lot of providers in larger organizations get their salary based off of their RVU, and if you're in private practice, that RVU is going to really correlate with your reimbursement. If you're a private practice provider that wants to maximize your reimbursement, let me tell you about Gentum Health. Gentum was founded by a Stanford-educated physician and former Facebook software engineer that believes that physicians should be paid what they deserve and be paid on time. They developed a platform that uses AI and automation to maximize reimbursement and make sure that providers get paid faster than ever before. The platform is backed by Gentem's team of billers and coders that work with your staff to continuously coach them on improving revenue while also working with practice owners to learn the business of medicine and use data to drive decisions for the practice. Go to gentem.com/Victoria demo or click the link in the description of this video to get your free demo today. Now, if you want to look up an RVU, there are certain editions of the CPT manual or desk references that do have RVUs listed for the CPT codes and for the HCPCS codes. But you can also just find them on the RVU calculator on the AAPC website. I'll link that below as well in the description. And you can calculate your RVUs, and they have some more information just about RVUs in general as well. And then some of those Medicare contractors have that information on their website as well. So mine, Novitas, has a fee schedule online that you can go and type in a CPT code. It tells you what the RVU is, the fees, the global days, and all kinds of other helpful information. But you can get way more in-depth information specific to your practice by visiting my friends at Gentem. Again, the link is in the video description. So I hope this helped clarify some of the questions that you have about RVUs, and I hope you'll consider subscribing. Also, if you want more information, remember I talked about bundling. Bundling pertains to the NCCI, and it's the National Correct Coding Initiative. And if you need to know more about bundling and NCCI, this is definitely the video that you want to check out. I will see you guys in the next video, and until then, just keep on coding on.